Yeah, I think so. Okay, a very good morning, ladies and gentlemen, members of the floor. Again, this is the last day of the conference. It's an early Sunday morning. Thank you for being here. I appreciate your attendance here. I'm happy to share a partial aspect of my PhD study research, which is the post-COVID financial toxicity of cancer in Malaysia. So I'd like to acknowledge all the site investigators that have contributed to this study. Without them, this wouldn't have been possible. And I'll start off with talking about Malaysia. So we know it's a dual public-private healthcare system where in the public setting we have Ministry of Health, University and Army hospitals. It's generally funded through taxation from the public, and there are minimal fees for all Malaysian citizens regardless of whether they have private health insurance or not. And on the flip side, we have the private side, which is predominantly for-profit, funded by out-of-pocket payments and mostly private voluntary health insurance and government-mandated savings. So what is financial toxicity? This is a buzzword we are hearing of late. It's the in thing now. However, there is no standard definition per se. A lot of literature articles have defined it as objective financial burden caused leading to subjective financial distress. Okay, so this is how financial toxicity is perceived, and it reflects the detrimental effects of direct and indirect costs of cancer on the patients as well as their families. So what are the components of financial toxicity? So the most obvious one, of course, is the objective financial burden. This is the active spending that they spend on the drugs, on their clinic visits, on the cost of consultations. This is the percentage of health-related spending which is in relation to their household income. Subsequent to that, I think it's other things that follow as a domino effect. So you have material responses where there's inevitably a change in income because there may be a loss in job, or they may need to look for additional sources of income. They need to sell their assets to get more cash in hand, or they even miss bill payments because they need the cash to pay for their medical bills. Other than that is also psychosocial impact. I think was very nicely described by Ms. Sudha before me on the emotional well-being of patients. So definitely there's a change in motivation, productivity and mental health. The next one is support seeking. So they actively seek for financial assistance. Inevitably, there's also coping care where they start cutting back on prescribed medication. So this is a form of saving money, and they try to, in a 1 month course of medication, they try to prolong it to 1.5 months or 2 months. They cut back on their prescribed medications. And finally, there's coping lifestyle. So not only cutting back on their medications, they also have to reduce their leisurely activities. So cut down on family outings, going out, spending money, which is now deemed unnecessary. These are the things that actually constitute financial toxicity when we talk about cancer patients' life. So what has been studied so far in this area? So naturally, before this, traditionally, the economic burden of cancer has always been viewed through a health system perspective. So how it's affecting the health policies, how it's affecting the health institutions. But of late, recently, there is more emphasis on patients' perspective. So this is one of it. It's a study, it's the ASEAN Cost in Oncology Prospective Cohort Study, or well known as the ACTION Study, published in 2017 by a group of experts from the region, including Malaysia as well. So this study is a longitudinal cohort study of 9,000 patients throughout the region, and they were recruited within 2012 to 2014. 8 countries were involved across ASEAN countries, with 47 public and private hospitals involved. So patients were followed up in the first year after their cancer diagnosis, and they were given some study tools. So one of it includes a cost diary where they input information on their household level incomes as well as out-of-pocket expenditures throughout the 12 months. So in Malaysia, we contributed to about 17% of the population with about 1,600 patients. And I'll jump straight to the catastrophic expenditure findings. So it's interesting to note that yes, there is presence of financial catastrophe in cancer patients after a year, even diagnosis, and we do see a range. So it's starting from as low as about 24%, right up to Vietnam demonstrating 60+% of financial catastrophe in cancer patients. Malaysia also falls somewhere in the middle, 40+%, and it is actually higher. The financial catastrophe seen in Malaysia was higher than our neighboring country, Thailand. So then the group in Malaysia did a subgroup analysis led by Prof. Nirmala from UM, and this looks at the Malaysian cohort and what was the what were the factors associated with financial toxicity as well as the cost drivers. So what we see from Malaysia, it's interesting to note that in all institutions, so MOH, university, private or overall, it's not only conventional medical care or traditional medicine, but it's all payments related to illness. So this includes things like transportation, accommodation where they need to stay near the hospital, childcare if they need to be away from their children. All this actually constitutes to the overall financial catastrophe that is faced by the patients as well as their families. So now we know that's been studied pre-COVID. So that was in 2012, 2014, published up to 2019. What is currently being studied now? So we know in 2020 we were hit by a very significant pandemic, COVID-19. And in 2020, I and my team, we published an article in eCancer reviewing the COVID-19 impact and its impact on cancer survivors. So most importantly and most obviously is the double financial hit. So now they not only have to look at the financial toxicity faced by the disease, they also had to manage the economic consequences of COVID-19, the impact from the pandemic itself. Secondly is the healthcare system strain. We know very clearly the healthcare system had to put all their resources to manage COVID-19. So this led to cancer patients maybe being neglected, their disease not being attended immediately, treatments being delayed because the resources were put for COVID-19. When treatments are delayed, we know the cancer advances. When the cancer advances, treatments get more expensive, eventually leading to more financial toxicity. Economic consequences, so loss of employment, loss of daily wages, especially the informal sector patients, those who get daily wages, every day of not working is reducing their income, and this would have impacted them significantly. Finally, social security concerns. So these are things like there's no robust protection, insurance protection for patients, and so they have to choose whether they are going to pay for their treatment or their basic needs at that time because of the loss of employment or loss of wages. So all this is actually a significant impact on cancer patients post-COVID-19 or post-pandemic. So there's an urgent action, call to action, where early identification of financial toxicity is very important so that these patients can be provided the necessary interventions at the right time. So my study, I started my PhD research smack in the middle of COVID, so it was 2020 onwards. So we focused on, part of my study focused on the assessment of the prevalence and contributing factors of financial toxicity in patients in Malaysia following the years of pandemic. For this presentation, I'm focusing on gender, ethnic and geographical disparities. So the study design was cross-sectional. We recruited patients from 21 to 22, so smack in the middle of the pandemic. And we had study sites from all over Malaysia, so predominantly in the Klang Valley area, as well as East Malaysia, so Sarawak GH and Hospital Likas. So we had adult cancer patients with any type of cancer, primary or recurrent, within 5 years since diagnosis. And we recruited 1,200 patients in this study. We interviewed them mostly face-to-face, some via telephone, and we used a questionnaire when we interviewed them to get their social demographic details, as well as employment and insurance-related variables. And on top of that, we also used the cost questionnaire. So the cost questionnaire has been validated by myself and my team, and we published this in 2023 last year in the Cancer Care Research Online. It's been validated in both English and Malay languages. So 720 patients were recruited, respectively, with a fair share for English and Malay language, and This showed that the cost questionnaire is a psychometrically robust questionnaire that we can use to determine financial toxicity in patients. So we'll go to the results in terms of demographics of these patients. Out of the 1,200 patients, majority of them were female, mostly within 50 to 69 years of age, mostly from MOH hospitals. And it's interesting to note that out of 1,200 patients, only 1/3 of the cohort was employed when we recruited them at the time of study. And most of them fell within the B40 income category. So if you look at the map here, we have most of the patients, 70% from Peninsular Malaysia, but we have a good representation from East Malaysia as well, about 30%. And if you look at private insurance ownership, overall, not so satisfactory. Less than 30% of the cohort had private insurance ownership. But if you compare between the regions, it is quite distinguished difference. East Malaysian patients, less than 10% own private health insurance. But it also could be attributed to the fact that our study site was government sites, Hospital Likas and GH Sarawak. So this could have been a confounding factor here as well. In terms of the ethnic distributions, majority of the patients were Chinese and Malay patients, followed by Indians and Sarawak origin patients. So we'll go to the prevalence of financial toxicity. We present the results here categorically. So any score of 14 and below is considered severe. I forgot to mention this earlier. The cost questionnaire has 11 questions. It's a score from 0 to 44. So the lower the score, the higher the financial toxicity. Okay, so anything below 14 is determined as severe financial toxicity. And in Malaysia, in our cohort, 1/5 of the patients presented with severe financial toxicity. When we look at the median cost score, it was about 24 for the whole cohort, which is about moderate financial toxicity. But when we compare between the regions, East Malaysia and West Malaysia, East Malaysia had a lower median cost score among their patients. If you look at region and ethnicity, West Malaysia and East Malaysia, severe financial toxicity. So anyone who scored below 14 in their cost score, close to 40% of patients in East Malaysia actually are facing severe financial toxicity. So this is something alarming. I think it's a call to action for us as well. And when we look at ethnic distribution, the Sarawak indigenous patients, 50% of them, so 1 in 2 patients would be facing severe financial toxicity. When we look at gender, okay, this is something interesting that I'd like to discuss also. When we look at literature, typically it is shown that female patients face a lot of severe financial toxicity. But in our study, it was the opposite. We found that male patients had a higher level of severe financial toxicity, close to 30% of them. This could be attributed to the fact that 70% of our population were from the Klang Valley region. We may have more empowered women in this region, so they are self-sufficient, they're working. Or it could be that the male patients that were in this study mostly were providers of the family. So when they are affected by cancer, the household income reduces and financial toxicity hits them hard. So some of the predictors of financial toxicity are age, education level, monthly household income, gender, center of treatment, ethnicity, and employment status. When we do a gender stratified analysis, we do see that cancer stage is also something that impacts female patients, but not education level. Education level is only seen in male patients. So these are the differences between the genders. And we then ask them their perception on financial status. So we ask a very simple question. Do you meet basic needs? Surprisingly, both from West Malaysia and East Malaysia, more than 90% of them said yes. But when we ask the following question is, how do you perceive your financial condition in the past 6 months? You see a difference. Double the number in East Malaysia actually reported as themselves as poor or very poor. So this is something that we need to take note of as well. When you ask them simply if they meet basic needs, the general response, I guess, maybe the culture in Malaysia would be to say, yes, I'm okay, I'm fine, I meet basic needs. But when we ask them on their financial status in detail, do you feel that your condition is poor or very poor? Close to 20% from East Malaysia actually said yes. And when we look at economic hardship, so this is post-cancer survivorship, right? What happens when they are diagnosed, they lose their employment, have reduced income. So what's the status like? In East Malaysia, more than 50%, 64% patients reported having reduced income post-diagnosis. So this is extremely alarming. Only 4 out of 10 patients would have a maintained income post-cancer diagnosis in East Malaysia. In West Malaysia, it's slightly better, 30% report having reduced income. So we did a multivariable logistic regression and we saw that patients from East Malaysia were 3 times more likely to experience severe financial toxicity compared to those in West Malaysia. So what are some future recommendations from these findings? We know there's a lot of unmet financial needs, long-term needs for cancer care, the fact that private health insurance is limited, non-medical costs are not covered, lack of assistance in dealing with loss of employment post-cancer. Also, the system to obtain financial support is not the easiest for patients, and also their existing debts if they have any. So it's very obvious that there is concerning geographical disparities in financial toxicity amongst West and East Malaysian patients, with East Malaysian patients showing higher financial vulnerability and financial toxicity following cancer. So there's an urgent call to action, a need for early interventions to alleviate financial hardship and also to promote equitable, so I should have bolded this word, but equitable access to quality cancer care throughout the country. So next steps, as we have validated the cost questionnaire, so using this as a screening tool in hospitals as well as community settings would help for early identification of financial toxicity so that appropriate assistance can be given in a timely manner. Also, complementary role of private health insurance is seen to be very important here in reducing financial toxicity as well as improving access to cancer care. And finally, development and implementation of financial navigation programs would be very helpful in this situation. I'm also happy to share that in University Malaya, we do have a team that is working on a financial navigation program. This is work in progress where we aim to train staff from governmental agencies, NGOs, and the community to assist with patients in terms of financial planning, financial aid, and return to work after cancer. So these are some of the stakeholders that have been identified, and this is a work in progress, so watch this space for more information soon. That brings me to the end of my presentation. Thank you very much for your attention.